Please welcome Dr. Koliwad.
Great, thanks, Kirk, for the kind invitation, and thanks to all of you for being here today. I look forward to being able to talk a lot about safety. We've been dealing with that issue a lot at UCSF and at medical centers and medical schools and other healthcare institutions around the country because we have the dual set of issues to deal with, and that is the same set of issues you have to deal with. That is educating a diverse population of students in pharmacy, nursing, dentistry, medicine, and graduate education, as well as dealing with the fact that, after all, people who are the sickest with known COVID come specifically to our site for their care. And so we've had to balance the issues of safety, being able to provide sound clinical care, and being able to push forward the educational objectives that are so important. So I'm an endocrinologist. That means in part of what I do is to take care of individuals with diabetes. And as you know, diabetes patients are at the highest risk, or at least among the highest risk patients for poor outcomes with COVID. And moreover, I have practiced for the last 14 years, clinically anyways, at the San Francisco General Hospital, which is where the indigent population in the city and county of San Francisco get their care for the most part, as well as the homeless population, undocumented population, and the it's the primary site for care for the Hispanic Latinx population as well. And as you know, these are the populations that have the highest rates for test positivity for COVID, as well as hospitalization for COVID. And so we've had quite an experience in San Francisco. And I'll take you a little bit through the history, give you a snapshot of what we've done to respond institutionally for safety on site for our people, and then maybe reflect those learnings back with respect to parallels that you all might take away as you think about how to utilize campuses most effectively in the educational arena in this district. We have taken both our kids through Burlingame schools, including Burlingame High School, and so we're very committed to making the public school system work here in the district. Okay, so with that, if we go back to the middle or end of February, we're now talking about 3 weeks after the Super Bowl. And many people at UCSF have said that it's really amazing to think that if we had won the Super Bowl this year, that there would have been a big parade afterward. And we would have had no idea about this threat that was looming and actually we now know circulating in Northern California as well as Washington State. And who knows what might have happened. And so it's just food for thought that we kind of dodged a bullet there without even realizing it, perhaps. But by the third week of February, UCSF had 2 cases of COVID. And in fact, UCSF had the first ICU case of COVID in the entire country. And by the end of February, California and New York had similar numbers of cases, similar numbers of hospitalizations, and similar numbers of deaths. If you can imagine, we were at the same point. They had a small growing outbreak in Westchester County, north of New York City, and we had actually at that time a relatively larger outbreak in Santa Clara County that led to the very first countywide lockdown anywhere in the country. And so we were really worried at this point because of our proximity to the Pacific Rim, a huge amount of travel back and forth between China and the United States through San Francisco and Oakland. And we really felt like we were going to be, the bullseye for this epidemic in the United States. And I think, gratifyingly, a lot of very quick decision-making and decisiveness, frankly, protected us at the local level, county level, and state level. And the reliance on some of those measures, even to this day, has allowed us to stave off some really large waves of infection that other places in the country have faced. And we can get back to that later in a moment if people want to talk about it. But I think that with that in mind, we did some things at UCSF that I'll get into in specific detail. But more broadly, I think we've had to figure out, how do we use the campus, use our educational environment to teach young people, in our case, graduate level students, about the quote unquote societal aspects of how behaviors in this current context and what we think might be necessary going forward will work. If people stay home and they never engage in any kind of process outside of the home that is organized in nature, then the school system loses its ability to teach behaviors to young people. And that's what we've been doing since kindergarten to young people, is teaching them ways of behaving. And we now have to accept the fact that understanding how to interact with people in real space in the context of a viral pandemic is one of those aspects of common behavioral courtesy that needs to be taught. It needs to be taught and learned and practiced. And school is the only place that we can really achieve that goal. So there is that reason for the thinking of in-person learning. There are also drawbacks to doing things online. We've dealt with those drawbacks at UCSF. And even in the context of doing a lot of stuff online, we realize that actually there are some things that just cannot be done properly in a remote fashion. And I think you will have to contend with the fact that that is true in education as well. But most importantly, I think what we've learned is the importance of building confidence. Confidence, confidence, confidence. Because the way we get past where we are right now is to overcome fear. So we could either wait and continue to wait, or, as you see in other places in the country, lose our patience and ignore health guidance and try to quote unquote reopen fully. Well, my professional opinion, and from what I've seen around the country and here, reopening fully without regard to health guidance is ridiculous. That is why we see waves of outbreaks and so-called wavelets now around the country, and we'll continue to see that as long as people completely ignore healthcare advice and county level guidance. But waiting and waiting and waiting also has its drawbacks. I think that there is an appropriate middle ground that allows us to achieve goals, keep safe, and avoid the fact that, given that we don't have a vaccine and probably will not have one to even offer people until sometime into the latter part of next year, and given that we don't have treatments, and even the ones that are in deep trials right now that look promising are only for the people who are the most sick with COVID and even those who are ventilated with COVID, this waiting issue could go on for quite a long time. And we even think that the vaccines that are going to come to the fore first are probably going to be modestly, if not only moderately effective. And that is to say that there are going to be plenty of people who take the vaccine and still get COVID. And so we're far from being fully protected through treatments and vaccine-based prevention. So we're going to have to do something until those days come. In the meantime, I think that, and we'll get to this, if it's possible to stay up to date, that helps reduce fear and increase confidence as well. And after this, I'm going to provide Kirk with some expert links through Twitter that I think are worth following. They include Bob Wachter at UCSF, Eric Topol, Andy Slavitt, Ashish Jha, Atul Gawande, Scott Gottlieb. And if you can, every once in a while, ignore the politically motivated aspects in some of these tweets, there are a lot of embedded study results and really great guidance for people. And I think educational environments can take a lot away from these experts who are really spending a lot of time providing sound advice and data to the public. And you don't have to worry about those names now. I'll make them available through Kirk, and he can pass them on. Okay, so then with that in mind, and this idea that there is a real role for in-person learning, teaching, and experiential knowledge, how do you provide that? So this is what we did. The first thing we did is to understand where the greatest risk was. And so you'll think about healthcare workers, especially in the first month of the pandemic, with respect to so-called frontline workers, people donned in full PPE, dealing with deaths in nursing homes, illnesses among staff in medical centers. And I think that's the image that people have. And really, truthfully, that represents a very small percentage, even in the beginning, of what was going on, and really mostly in New York and in nursing homes. And we had a very steep learning curve in academic health centers, the largest health centers that exist in any given metropolitan area for the most part. So the first thing we did was create cohorting strategies. So that's very similar to what you're talking about when you think about isolation. So the first thing we did then was to create COVID wings and dedicated areas where we triaged the COVID positive patients to be grouped together if they had respiratory problems. And that then allowed the people with the most know-how, the greatest amount of PPE, the most content knowledge to be the ones who interacted with people who were likely to be COVID positive the most, and saved and spared everybody else who was still in the building, still working in the hospital and in the clinics that we have across the street at Parnassus, for example, from interacting with the areas of highest risk. That was very, very useful. With that strategy alone, we have had, to my knowledge, 3 nurses that tested positive for COVID and had mild illness that required them to be managed. Of those 3, we now know that they were acquired in the community through contact tracing, not at work. We have since had a few other nurses be documented who did get COVID at work in the hospital, but none of those individuals got sick with COVID. They just went home, recovered, came back to work again. And now we're talking about that in the context of a place like UCSF, where you know that we're purposely wanting to bring people with COVID in. And I think that that's remarkable. And if you take the community-wide understanding of this, the rate of asymptomatic people testing positive for COVID has been less than 1%. In the Bay Area, all 9 surrounding counties, we're talking about somewhere in the order of 0.4 to 0.7%. So it's 99.3+% likely that if you don't have symptoms and you go in to get tested, that the test is going to be negative, true negative. Even if you have symptoms, respiratory symptoms, fever, some cough, runny nose, things that might make you get worried, even in that instance, it was 97% plus likelihood that you did not have COVID. You just had a cold or some other cause of respiratory symptoms like asthma or smoking-related lung disease or something else other than COVID. So the true positivity rate in the community is quite low, and we didn't see much more than that even at UCSF, where we're a magnet for the actual true positives. So that was very reassuring to us, and it created confidence in our nurses, our staff, physicians, students, and everybody on site that we were not in as high-risk an environment as we thought we might have been. The next thing was the social distancing, and that has gone through till now, and it's just ingrained. So like if you go to UCSF, you'll see that like in the physician area, every other computer has an X over the monitor, and no one can sit there. And in the bathrooms, every other sink has blue tape on it, and no one can use that sink, and it's just every other. Same thing for urinals, same thing for toilet stalls. And we have just sort of gotten used to the fact that there is this distancing element built into our daily life at work, and I think that is very much aligned with what's going to have to be the case in schools. And it works. It works beautifully because people get used to it rapidly. They start just integrating it into the way they think, and they take it for granted after just a few days of doing it because it makes sense that we would be a little bit further apart right now. It's not foreign to people. They're very happy to be able to be on site, and they're very reassured by knowing that it just looks less dense than it normally would have looked. Right off the bat, people feel better when they see that. The next is the universal masking policy. I think that's really the most important thing. And all of the information I sent really has to do with the wonderful benefits of wearing a mask. And we're not talking about N95 respirators. We use N95 respirators in hospitals when we're doing procedures where we know that there's going to be aerosolized particles kicked up from people's mouths because of specifically what we're doing. And we're very close face-to-face with those patients at the time we do those things. And then, of course, people who are working with people who are sick with COVID in the ICU environment. That's where all the N95 respirator wearing is going on. The rest of us, me included, we're wearing simple masks, the basic surgical type masks, and even in our laboratories, cloth masks. And it's proved to be wonderfully effective. And our rates of transmission at UCSF, we have not documented any of that at all. The next thing is hand washing and sanitizing. So when I come to work in the morning, I know that the tabletop has been sanitized. I know that the computer terminal has been sanitized, and the phone that I'm going to use to do my my video or phone visits with patients has been sanitized. And the reason I know that is because when I arrive, the phones are placed off the hook. The mouse for my computer is placed on the keyboard, and those are indicators that the cleaning crew has been there and done the sanitizing. And it makes me feel good to know that that's all been done, and I'm the first person to touch it since it was sanitized. Hand washing and gel hand sanitizer use. Let me just say a word about hand sanitizers. Many people think about hand sanitizers in the context of bacterial infection, with resistance being able to develop in the context of sanitizer use. That is not the same for viruses. So alcohol-based hand sanitizers kill the cell wall of the virus, and there's nothing really that the virus can do to create resistance to that. It's not an antibiotic-based approach. And so as long as we use hand sanitizer, it will be effective. And so I can't emphasize enough that it's very reassuring to see lots of hand sanitizer stations everywhere, and just keeping them full and having them in the classrooms and having them in hallways and upon entry into the school. Those kind of things go a long way, and they work. And then universal screening, and I sent the information for Conversa Health, which is who we use. And if people want, during our Q&A, if we have a few minutes, I can even show on my phone how I go through it. It takes maybe 20 seconds to answer some questions, and then once I go through that screener, if the answers are all negative, then I get a separate text message that I click on. It gives me a QR code and an approved for 24 hours thing. I show it. I get a sticker from the front desk people at the hospital or at the laboratory building, whichever way I'm coming into the building. And I put that on my badge, and I'm good for the day. And it has the date written on it, and I feel confident. And everyone who sees me knows that I've gone through the screener, and that's very useful. Temperature checks, it's interesting, actually. We don't uniformly do it the same way everywhere. Some hospitals do temperature checks. There, for example, at the General Hospital, we do temperature checks because, again, we have a lot of homeless patients. We have a lot of undocumented individuals, people who are Hispanic, Latinx, essential workers, people who are living in extremely high density housing. So we want to know if there are people who are actively sick coming in. But at UCSF, where the likelihood of that happening is much lower, given the demographics of people who go there for care, we don't do temperature checks uniformly. And when I go to UCSF, I don't always get a temperature check. And then I think I'll leave the rest in the context of the Q&A, but I'll end only with testing. And so we have not done a widespread weekly testing approach, even at UCSF. And the reason for that is that if you're going to do testing, you have to do it very frequently, because of course you can be test negative today and acquire COVID tomorrow. And so the question is, how frequently do you need to do testing to really have it be useful? And as far as antibody testing is concerned, we are still planning on how we might integrate that. But again, we don't know that the antibodies are fully protective, and we don't want to give people a false sense of confidence that they're completely ironclad and protected simply because they have one test that says they have positive antibodies, suggesting that they got over COVID already. Now, as far as the testing is concerned, the one thing we are doing, and I might make a recommendation that you consider, is we have yet to roll out, but will roll out a random testing every week of 100 unselected, randomly selected people at UCSF every week. So we have a different cohort of 100 people out of our several thousand on campus that get tested. And if we see a blip in that random testing, we know something is amiss that might be overall impacting our population over the next couple of weeks, and we can make calculated decisions about how to draw back things on campus or continue to move forward in a graded manner. And so that's something that you may think of. And so with that, in the middle of May, we moved from the early part of late March, early April, when we locked down fully and closed our labs, pulled all the on-site learning, graduate classes, medicine classes, every class to remote, just like you did. Really no difference. We've gone to 12.5% occupancy in mid-May, and we're now at 25% occupancy on site. And we plan to go to 50% occupancy if nothing changes within the next month. So we've done it in a staged manner, and I think that there is some value to the concept of doing that. It doesn't have to be that slow, but some sort of staging so you can test that things are working okay and you don't see any blip is useful. Okay, And then finally, I'll just say, motivations for this. Well, of course, UCSF, like all hospitals right now, is losing about $3 million a day by not having people come back in and get care. So there is, an ulterior, if you will, motive for why we might want to reopen and get things back to normal. But our job as educators and as people who run the educational enterprise alongside the healthcare enterprise, we need to make sure that it's done safely. And I think that's also very analogous to your situation in schools. You want to make sure that the educational objectives can be attained, and that we're not wasting money that is valuable public funds for education by doing what we think might be a lesser version of education online, but we need to be safe. And so I will stop there. I think I've touched all the issues, and maybe just go quickly to the questions that I first got. The first one was that many who have contracted COVID-19 are asymptomatic, and what can we do at the school level to reassure staff, students, and parents and keep the risk of spread low? So I think it's precisely because of that issue, and we see that at UCSF too, because we have lots of 20-somethings that populate all our buildings. If they're going to be positive, almost always going to be asymptomatic or pre-symptomatic or mildly symptomatic. And hand washing, hand sanitizing, physical distancing, and masking are incredibly effective, particularly for this population of people who are not displaying symptoms at the time. And I can't overstate enough, and all the studies that I've passed along prove the value of this, that those measures essentially crush transmission. It's only those kind of measures that got countries like New Zealand, South Korea, and other places to go essentially to zero. They did not do much else except for contact tracing, and we're going to be doing contact tracing now. We are doing it in San Mateo County, and so that's already in place, and you will have access to that contact tracing should anyone test positive. So the next question was about school-wide testing. What would be the interval? So I think, again, I kind of mentioned this, but we're thinking about a random testing approach, not to highlight or find anybody who's positive and do stuff with isolate them in particular, although that will happen. But it's more so to get a snapshot. And we're thinking about a weekly way of rolling this out. It's much cheaper than doing everybody. It provides very actionable information, and it gets you ahead of the curve by 2 or 3 weeks with respect to anything like a potential outbreak far before it might happen. And I think that's quite useful to consider. Fever. So remember, like I said, if a kid has fever, if a staff member has fever, if a faculty member has fever, it is right now in the Bay Area more than 97% likely that fever has nothing to do with COVID. So just make sure you remember that as a fact. That's been proven in every state. There's no state really where it's too different, although during some of the waves that we've seen in New York, for example, we've come to almost even 10%. But if we ever get to that area, we will know, weeks and weeks in advance that we're headed in that direction. So for now, if a kid has a 100-degree temperature, they should be tested. They should stay home. If the test comes back negative, then I would probably keep that home until the fever goes away, just like you would normally. But I would really enforce that policy. And if somebody tests positive, then I think you have to let them get better, have the fever go away. You wait 14 days and you let them go back. Asymptomatic positive tests, 7 days. If they never get any symptoms, you let them go back. I think there's strong data that says that those are prudent measures to take with respect to being able to go back. And then underlying conditions, and this is something very important too. I didn't mention in my initial talk. We have taken that into consideration, and you will end up doing that as well. And I think that some of this stuff is already negotiated. Some represented groups already have these issues in place as protection measures, and I think districts are already taking them into account. But we are allowing people who are, have as you say, predisposing conditions like diabetes, heart conditions, lung conditions, or who are immunocompromised, the ability to try to find ways to do their work at least from home. And we create sharing mechanisms where various elements of teaching work are shared between people, and maybe lectures can be done from home that span across multiple classrooms and in-person learnings can be done in smaller groups by people who are capable of going in because they're relatively healthy by comparison. And so, this idea of how it works in many universities, where you have a lecture session given by a lecturer that's common for a class like calculus or whatever, and you have discussion sections that are managed by other teachers of calculus who are able to do those in small group environments on campus, utilizing outdoor settings, for example. You can really keep the risks down. And then, of course, if somebody has an illness at home, somebody has to care for someone with COVID. These are all relevant reasons, and there are others as well, why people will have to pull out of the general plan of coming into work. But outside of those things, we have a very egalitarian, very esprit de corps driven alignment between our faculty and staff, and the idea that we're all in this together, and that we've all got each other's back. I think that ethos, that culture, is central to making these kind of things work. And once people realize, like, when I wear my mask, you're protected. When you wear your mask, I'm protected. All of that general concept, it permeates through the entire environment, and everyone starts thinking that way. I can add also one other comment to that, to say that even 50 to 60% mask wearing, such that you have some a lack of masking, even that's very, very protective. 90% plus is extremely protective. So the idea that, kids might not wear masks, even if they don't wear masks here or there, you can tell when someone's not wearing a mask. It's really easy, right? You can't tell as well when someone didn't wash their hands, but you can tell when someone's not wearing their mask right away. If you ask them to put it on and they do, then you've accomplished something every time you see that. And if that happens here and there throughout the school day, you manage it right there in the moment. We don't have to have necessarily a big disciplinary element to that, but it starts to build in as a culture over time, because the students realize how valuable it is to be on campus, how they feel about it, how it makes them feel, and that sense of positivity for everybody. And they know that if they don't align with the culture, they will lose all of that. And I don't think any student really wants that to happen necessarily. And so I think, there's a balance that gets struck, and that we see working, at least at our place. And we have a lot of, protest related issues going on, especially in the context of the current environment with respect to racial equality, and lots of reasons why people want to gather, but they still are doing so within the confines of basic courtesy. And I forgot to mention one other thing that I think is really valuable, is to have an in-service and to have an educational module for students, educational module for teachers, staff, families, to let them know how we're rolling out what we're rolling out, what the policy is, what the science behind it is, and have weekly check-ins, so that we can make sure that the messaging continues to be maintained, and the idea of the culture continues to be expressed on a regular basis, so everyone keeps seeing it, and some mottos end up getting developed, and those are really useful as well. So I'll stop there. If there are any other questions, I'm happy to handle them. And also, even offline, if people want to email me or otherwise ask questions, I'm happy to try to answer those that way as well.
Dr. Koliwad, we have a few on the chat stream, and
Sure.
So I'll just name.
Yep, I can see the chat if you want me to just read them off and start.
Sure.
Yep. Okay, so let's see here.
Start with
why are we not hearing from an epidemiologist? So that's a good question. I work with epidemiologists a lot, and I do diabetes-related epidemiology. All of the links I provided with respect to Twitter feeds that are very useful in my opinion are specifically from epidemiologists, or presenting data that are derived by epidemiologists. So the best person I think that people should follow is one of my colleagues with this in mind, with respect to Bay Area specific information, and that is George Rutherford at UCSF. George Rutherford is one of the preeminent epidemiologists in the area of COVID, and is specifically focused on COVID related trends and model-based predictions for the Bay Area specifically. And you can also go on UCSF's town halls and grand rounds, and I can make those links available as well if someone just reminds me. And George Rutherford usually gives a 10-minute introduction at every one of those meetings to update people on the current epidemiology of COVID right now. He's excellent, very easy to understand with respect to how the data are presented. and is also very reassuring. And again, emphasizes the benefits of masking and minimal social distancing principles on transmission, and highlights the fact that in every place where outbreaks have occurred, they've occurred in places where, at least since New York, where people have not engaged in those kind of behaviors, population wide. And so the other part of that was comparing people in their 20s and adults to middle and high school kids is like comparing apples and oranges, and that is true. We are entering a new frontier in this regard with respect to kids. We do know that kids develop separate illness when they get COVID, but we also know that kids don't get COVID as frequently, even as young adults get COVID. And we also know that when kids get COVID, their rates of developing symptoms are even far lower than adults and young adults included. So there's pluses and minuses when we're talking about COVID acquisition, and I'm aware of the epidemiology on that very well because I take care of children as well as adults in my diabetes practice. Separately, with respect to kids, the transmission, even though it tends to be asymptomatic, we think is actually less aggressive with kids than it is with adults. Although kids are asymptomatic and can sort of lurk under the radar because of the lack of symptoms, if you have policies in place to manage everybody, then that's the best way of dealing with people in that segment of the population, because otherwise you'd have to test people every day, and that's not feasible. And so, yes, it is the case that we're going to have to have some pioneering spirit with respect to the fact that we're talking about kids and adolescents. But if we wait, the point I'm making is that issue doesn't go away simply by waiting. It'll be the next semester, same exact discussion, and the same exact points are valid. Next semester after that, same discussion, and the same exact points are valid. And until there's a vaccine or an really effective treatment for mild illness, and there aren't even any trials that are hinting at such a thing right now, we won't be able to stave off those kind of discussions. So on the other hand, if you show that an approach that is effective for rendering teaching and also safe works by doing it, then we become our own experiential vehicle for future guidance, because we're not going to be able to get top-down guidance from any epidemiologist on this because there's no data to guide us with respect to kids. The only thing we can say is that the virus works a certain way whether it infects a kid or whether it infects an adult. The virus is the virus. We know a lot about how the virus works. We know about the impact of distancing. We know about the impact of masking. We know about the universal benefits of hand washing, sanitizing, and surface sanitizing. Those things are beneficial whether you're talking about infants and daycare population of children or the elderly in nursing homes. We are not producing any different guidance on those 3 points across the entire age spectrum. So then that leads nicely into the next question from Dennis about transfer on surfaces. We do know that shiny surfaces, so-called, transmit better than porous surfaces. But to be honest with you, the more we have studied this, the more we are confident that surfaces are not the vector for transmission of this virus. So it is plausible that one could get the virus by touching it right after somebody with active symptomatic COVID touches it. But outside of that, we are really de-emphasizing the issue of fomite or surface-driven transmission towards really focusing on person-to-person transmission through the things that I just mentioned. And so with that said, disinfecting surfaces on a regular basis throughout the day and encouraging hand washing and making the hand sanitizing stations as available as we can possibly make them is really the way that we deal with this issue of surface transmission. So then the next question has to do with a positive test. If somebody tests positive, so then, again, epidemiologically, and this epidemiology does include young adults and even children. Epidemiologically, that person is likely to be asymptomatic with that positive test. And if they're symptomatic, the screener should not let them go into the school. So these are the ways you capture these populations. But if a student reports that they were exposed to the virus or tested positive and let's assume that they're asymptomatic, then they should be sent home, and they're going to be home for 7 days, most likely. And there's going to be a report that's sent mandatorily to the county, and the county will engage in contact tracing along with that isolation, so that we use a means to understand who that person was in contact with over the prior 72 hours, make sure that they all get tested, and so on. And we know that in other places in the world that have adopted that kind of approach very aggressively, they have really quashed any outbreaks. It's exactly this isolation and contact tracing combination that works the best. And we're now trying to get 20,000 plus contact tracers in San Mateo County to engage in this effort, and we're well on our way to achieving that goal. So I think that the people power should be there to do the back end work for the contact tracing and isolation. In any in-person model, will it not just be the cohort who has been potentially exposed due to mixing and staff? You know, that's a complicated question, I think, because I'll give you the example based on our experience at UCSF, and Stanford is very similar. We're in close touch with each other, as well as UC Davis on this, that the people who worked on site at UCSF and tested positive, they underwent contact tracing. And the contact tracing that they underwent found that in the vast majority, I mean, like almost all of the cases, they actually caught COVID in the community, going to the grocery store or you know, whatever it was, as opposed to getting it on site. So if somebody tests positive for COVID at school, it's very likely that they didn't actually get it at school, that they got it somewhere else, and we just caught them as being positive because the only place we're doing the testing is at school. And so it's going to be interesting to see how that plays out. My prediction would be that when you find students that test positive, you'll see that some of them might have got it from a friend, but they might have gotten it from the friend because they both were exposed to somebody at the corner store or whatever, and they got it in that environment, and that's where they got it from. And that will lead to a whole other you know, vectorial map of contact tracing that emanates from that corner store instead of the school. And so we need to be open-minded about the fact that just because school is a place and it's a place where people go, it doesn't mean that that's where they're going to be exposed to the virus. If you maintain distancing, it should not be the case that they get exposed to the virus through that route. We haven't seen at UCSF, where the number of people and the density is even much higher than what we would expect to be the case at our high schools, that we've had person-to-person transmission in that environment. Rather, that environment has caught people who caught the virus elsewhere because we're doing so much testing in that environment. That's the way I think it's going to play out. Okay, so San Mateo High School PTO. I'm not sure why you think distance learning is inferior. So that's a very good point. I think that I don't know that distance learning is inferior because someone has a bona fide study that shows exactly how inferior or equal it is. However, I will say that what we found at UCSF is to be the case is that people like teaching to a person, to a teacher, when surveyed. They like teaching in the way they're most used to teaching. It's like asking yourself to use your left hand when you're right-handed. You'll do it, it'll work, and you'll probably do a decent job at it after some weeks of training. But if I ask you which do you prefer to use, you'll say your right hand. And so the same thing is going to be true here. People will do distance teaching and distance learning, and they might see other benefits to be gained from doing so. But I don't think if you then survey people anonymously and ask them after the fact, do you think that you were better in this environment, that all the learning happened just as well, that you're going to get people saying, yes, uniformly, I feel like it was just as good. But we will know that when we conduct that survey, and I think that that's a kind of survey that really needs to be conducted. We've done a lot of that sort of self-assessment at UCSF, and there are a lot of differences between our environment and yours. Of course, you know, the fact that our faculty are not represented is only one of many differences that we have. But if you can get honest answers from people after the fact, then you can tailor this subsequently in each semester to align better. But that said, I do think that you're going to have some online element, and it may be a very significant online element, because you can't have the social distancing on site without meaning that some people are off site. those people who are offsite should be getting learning, and that learning will inherently be delivered online through remote means. I think that the goal should be to produce the online modules that are the highest quality and the in-person modules that are the safest. If you can match those things as well as possible, you will get an outcome that I think is quite reasonable, that you will be happy with. And so, you know, I'm not going to get into deeper curriculum discussions because that's not at all my area of expertise. But, you know, in terms of safety, that would be the idea. And then discipline among students. Yeah, I think this is reasonable, a point to bring up, although I will just harken back to some of the studies that show that even a modicum of mask wearing, most of the people following the rules, is amazingly beneficial to the overall safety of the group. It's not like one person not wearing their mask, you know, spread the virus around the school, even though everybody else was for the most part wearing their mask. It doesn't work that way. And I think that, you know, if somehow there was like a, you know, mass protest and everyone just took their masks off all of a sudden and said, we're not doing this, well, then that's a different situation. But that would be akin to, you know, some other kind of mass demonstration, even pre-COVID. If all the students did in unison, it would be sufficient to shut the school down. So, I mean, those are hypotheticals, but I think in the context of normal lack of discipline on the level that we see in general in schools, it's not going to be enough to overcome the mask wearing by everybody else. And so, yes, we'll share everything. And again, I'm very open to answering any questions, trying to give the data to the group as best as I can, and our experience at UCSF and other institutions I'm familiar with as best as I can. Screening should be quick. So my screener online, I won't do it in front of you all. It takes me 20 seconds to go through. So as I you know, come in, as I get out of my car, I sort of just sit there and do it in the car. 20 seconds, I bring it, I just show it on my way, and I walk right through. And so it's actually real. When you have an app to do it, it's like there's no line at all. Everyone's just walking through, showing their pre-filled out questionnaire on the app with the good to go symbol, and you just walk right past. Okay, and they just look at that and some kind of a badge or some kind of insignia that says you're actually a student at the school, and that combination gets you right in the door. It's that simple. N95 masks I spoke about. Expiration date on the valve is important to note, but I'll also say that the N95 masks with valves are not as safe as the ones that don't have any valve. So I would recommend people who think about using N95 masks to use the ones that are just standard fitting circular masks and not the ones with those little breather valves on them, because virus oftentimes escapes through those valves, and you know, then you're amenable to not being protected, even though you think you are. Okay, I think that's all of the chat questions. If there are any other live questions, I'm happy to spend a few minutes, but I know I kind of went over time, predominantly, thankfully, due to the questions. If there's anybody who has other questions that they want to ask me offline, I'm happy to take those as well.
I have a question, Dr. Koliwad.
Yep, I see you.
Hi. I'm the president of the Teachers Association, and I thank you for coming here. I would echo, and with all due respect, I would echo the concerns about hearing from an epidemiologist, because I know for a fact that two of them have reached out to the district, and there has been who are connected with our district, and there's been no response from our district to engage in that discussion. So I'm a little concerned about that. I also want to just point out a couple of things, and I also just that I think that it's unfair to. Well, I think I shouldn't say unfair. I think you've characterized a lot of the concern about this as fear, and a lot of the idea of why people don't want to come in back to school is fear. And if you, I know you saw your my presentation at the board meeting. I saw you on the chat. And so I wanted to make sure you understood that the reason that teachers are concerned about coming back into the classroom for in-person learning has little to do with fear. I mean, sure, fear is a factor, obviously, and especially for those of us who are in high-risk categories or have family members who are high risk. But the two prongs that I described at the board meeting were what we can do best with what is safe right now. There's just on a practical level in terms of education. You mentioned, if we can find an effective teaching strategy that is also safe, that's what we should go with. And right now, the in-person models that we're talking about, because of the physical distancing, as you describe, and mask wearing and smaller cohorts, which I wholeheartedly agree with and completely am behind, we will not be able to engage in any effective teaching because we will not be able to do group work, no elbow partners, no turn and talk, no collaborative groups, very little movement around the classroom. As an aside, those cohorts will be mixing with other cohorts due to master scheduling issues. There's no way that we can develop a schedule where a single cohort of students can stay together. So for that respect, we've looked at the idea of the best model to increase the learning of our students is to have a robust synchronous distance learning model that ensures instructional time is delivered at near or very near the same amount that they would get in a normal environment. In an in-person environment, we would be having kids on campus, and again, that very structured, rigid, restrictive environment. And you mentioned having teachers do some distance learning while they were off campus. Well, there are no other teachers to do that. So when the students are home, they would be doing asynchronous learning, probably watching screencasts or videos and not being engaged in any direct instruction. So the distance learning model, it makes sense pedagogically, but it's not at all about fear. The reason for that is simply to increase the opportunities for learning for kids versus this environment.
Got it. Craig, in fact, I will say that, my role wasn't to
understood.
The what's the better and more effective way to teach students. I mean, that would be way outside of my purview. And in fact, I'll say that, if you boil it down, my role, or why Kirk, I think, invited me, was just to lay out the historical narrative of what we did, and what sequence we used to do it, and what outcome that had for us, so that people can see what that looks like. And that doesn't mean that that there aren't other specific issues in a high school setting that are different. There obviously are plenty of issues that are different, but at some point, there's going to have to be a guidance-based thought process placed on what does school mean anymore, and we're going to have to translate experiences from other arenas in order to apply them to this arena, because we won't have a lot of experience specifically within this arena to use. That simply can't happen, because it's just not possible to look at high schools that stayed on campus last semester and see what they did and how it worked, and we'll copy them this semester, because no one did.
No one's suggesting that either.
Right, and to the extent that that doesn't happen this semester either, then the following semester, i.e., spring 2021, we won't be able to look back at fall 2020 and see what high schools engaged in an in-person approach, because again, there won't be any examples of that. And so I'm not trying to influence how people approach this upcoming semester. I just want to make sure that, and the epidemiologists at the county level are great. I know the people who do that work, and our guidance at UCSF is also based on epidemiological input. But the epidemiological input that's the soundest, that is trying to govern any cogent approach to reopening any aspect of our society, is completely centered around masks, distancing, and hand washing / surface sanitizing, and we've made a lot of headway. It's amazing. It's a 100-plus-year-old approach based on the fact that it was used during the 1918 pandemic, and it's just as effective now as it was then. And despite all of our technological advances in the last 100 years, we don't have a better immediate effective tool than that one. Not because we haven't done anything in the last 100 years, but because that one is so incredibly effective. And I'm not saying that it's going to be the most spontaneous environment anywhere to have masks and social distancing. But whether we're talking about 2020, 2021, 2022, 2023, I think that students on campuses, whether you're talking about kindergartners or college students, are going to be wearing masks. If we think that era is going away because we wait, it's not. We're going to be wearing masks 3-4 years from now, unless something remarkable happens with respect to a vaccine that is highly effective. And no experts currently think that is, unless they work for a drug company, think that that's right on the horizon. So all I was trying to do is just highlight if. I'm not suggesting what should happen. If there is an in-person component, these are the elements we found that made that the most safe.
And no one's arguing with that, and I agree with you. I think even when
it was exceptionally safe in that context.
No, and I don't disagree. I mean, I think there are some real concerns about the types of masks that students will have. Even the article that you mentioned, the Dr. Gawande, he talks about how surgical masks and cloth masks are not effective in aerosol transmission or preventing aerosol transmission.
I mean, that is in the context of caring with people with COVID.
Yeah, no, I'm here.
It's a whole different story. They're highly effective in that context.
They're effective with aerosols.
They're effective with aerosols, with social distancing,
that's
and
fine.
In the normal social context that we're thinking about. In the healthcare environment where you're face-to-face with people and you're forced to interact with people who have a positive test, then the issue of what type of mask you're using becomes a very important one.
Sure. No, I don't disagree about masks. And like I said, I think we'll be wearing masks for long after we go back to even regular in-person instruction, just because of that. I think that's the nature of this pandemic. That said,
and so I can stop at that point, because this is beyond the rest of that discussion is kind of beyond my ability to.
I just wanted to make sure. You didn't misunderstand that what I was saying about the PPEs and the practices has little to do with the aversion to coming back, and it's more about what those practices will cause in terms of the effect on in-person learning. That, given the risk. And we've already discussed that if they're asymptomatic, we might not catch them, and we might see an outbreak, and we might have something.
Yeah. Well, the masking and the distancing.
Can I finish, please? I'm not trying to argue with you. I'm just trying to make sure you understand my point.
Mm-hmm. I completely do. Totally. So, and point well taken in that regard.
And I just want to make sure, just a couple of things that you hit on that I think are really important to point out. I think that if we can find an effective teaching that is safe and effective, that's the one that we should do. And you mentioned that you're not the education expert. We are, and I think we've found that model, and I think we believe that we can do that. I also would like to point out that the question you said, ask people about teaching, and I can say to a person, 525 members, would rather be teaching in person. I can guarantee you of that. And that follows with what the scenario that you described. I'm just suggesting that in spite of all that, we've looked at the options, and in terms of what's most reasonable and what's most wise in terms of where we are right now is just starting the year with a distance learning model. And those are the reasons, not because we're averse to wearing PPE, not because we don't want to hang out in 6-foot distance groups, not for those reasons. It's because we believe it's the wisest and the most responsible thing to do for the beginning of the year.
Totally understood. And I guess maybe to dovetail on that then, and find some common footing, is the idea that an approach to being together in the same space will be made to be most reassuring, particularly for teachers, when that happens, whenever that is, in a way that they understand that all of the best scientifically proven approaches will be guiding all of the aspects of how that day is organized, specifically to benefit the people who are on campus the longest, namely the teachers. And so that would be, and at UCSF, what we had to do in this regard, a lot of really very careful messaging and content delivery, so that the teachers knew transparently, like our faculty get a daily census and a daily countywide test report and a daily log of all the students who were screened and the number of students who screened positive and negative. And one of the things that's very important to making this really work, whenever that is that the teachers know that they're in it, they're part of it, and they're totally they're totally accessible or able to access all of the information that anybody else is accessing at the same time that they're accessing it. And that plus understanding through educational modules at lunch and evening sessions that are devoted just for teachers, to let them know what the newest data shows, what the newest trends look like, so that they know that there are people in the administration and in the district who are specifically looking out only for teachers in this. That's part of how these rollouts work, and we're all dealing with uncharted territory in this regard. But we had to kind of initially scramble and then work hard to develop new modules in this regard that never existed before at UCSF. And we'll deal with those things, I think, when the time comes. But whenever that is, these things all have to be done. There's a cultural component to this, too, that matters to get right so that everyone feels like they're being taken care of properly. And I think that's very important. Without talking about when it should happen, I'm just saying that those elements are part of it.
I understand that, and I think it should be criterion referenced, all of that. We should be making decisions based on data. I just want to, I've monopolized some time. I want to let other people ask, but I want you to clarify a couple of things that I heard you mention. One was you talked about, I think you used the phrase, and we will know that they test positive because we will be testing them at school. And so I'm wondering, and I'll ask two questions and let you answer both. I'm wondering if you're aware of some plan in the county or in our district or anywhere for testing at school, number one, especially when the county is still well below the state reopening guidelines for number of tests. And then also in terms of contact tracing, you mentioned 20,000 contact tracers, and I'm curious because the county's own variance application to the state just reported that they only have 30 when they're supposed to have 115 contact tracers. So if you could just talk about those two data points that I think are probably going to be meaningful for us because we've heard nothing about that.
Yeah. So with respect to the second question on the contact tracing, the goal of 20,000 contact tracers and the rate at which new contact tracers are being brought on board, I'm not aware of the rate at which we reach the number, but there's a steady line towards, reaching that number. And that number should be reached in a definable number of weeks to a few months. If you look at the basic context of what the goal is and how rapidly people are being hired right now. And to my knowledge, a lot of these people are repurposed workers who are doing other county health related work right now, who are now flipping into doing contact tracing as a result. So that's how they intend to get that number up at the level of the county. With respect to testing,
I'm just saying, I just want to be specific. The county just said that
I'll let the district answer where they are with respect to how many tracers they know of available to them to utilize right now.
Okay.
I'm not part of the district, so I don't know the answer to that question. I know what's going to be available and what the strategy is going to rely on for everybody who lives in the county, not just people that's in school, but all of us are going to be using the same contact tracing scenario if we test positive, wherever we are in the county. With respect to the issue of testing, all I did was put forward an idea. The idea would be that it is reasonable, because we're not doing it. I have never been tested for COVID. Okay, I work at UCSF. I go there every day. I take care of patients with COVID, as well as patients mostly who don't have COVID, and the ones who I've taken care of with COVID have been asymptomatic. I've never gotten tested because I've not taken care of anyone with symptoms, and I've not been exposed to anybody for long enough time that would have necessitated that I mandatorily get a test. And so I think that the idea of what the value of testing is something that's sort of permeating into the popular culture, and people think, well, we need tests. Well, that's a very nebulous question, because tests only tell you how you are that day.
Right.
And so you can say, well, we need to be tested every person every day. And then, of course, that's impossible. But what we are thinking of doing at UCSF, we have not started it yet, I was clear about that, is to test a subset. You know, in a building, that's got over 7,000 people total in it. And if you count medical center and campus side of our university, we're talking about testing 100 to 200 people a day. Okay, as a snapshot, a sentinel that shows whether that you see any cases in that randomly selected group. One could imagine that if that sort of approach was adopted in a school setting, it would serve the same purpose. And it would be a lot cheaper, easier, quicker, to roll out. And so I was putting it forward because our experience suggests that that kind of approach might be beneficial. But in terms of what they're actually planning to do or have done until now, I'm not part of the district. I don't know the answer to that question.
Understood. Thanks for the clarification.
Are there any other questions? And I guess the only other thing to say is that, you may want to prioritize hands-on activities that are really difficult to do, remotely, and put emphasis on how one might think about those activities, laboratory activities, art, things that are spatial by their very definition, and think of those things as scenarios. But I'll just leave you with this, that, we wouldn't have experimented on our students, at UCSF. If you think about putting people in an in-person environment as experimenting on people, then, I would take exception with that characterization. That is a very narrow-minded and unfounded and not data-driven or fact-driven way of thinking about things. We have not had a single student test positive because they came to school. And we're talking about thousands of students across all our schools. And they're not doing things that are remarkably rigid with respect to their behaviors. They're, 22, 23, 24-year-old kids. It's not like they're so grown up yet either. And it's quite a lot more dense than what we're imagining any high school to be looking like. And I just thought that knowing that that has been a safe experience should provide people with a modicum of confidence if they are willing to accept that information as guidance. And so I'll just leave it at that. That was the intention, is to provide the experience as a means for assistance with decision making if it can be used in that manner. But if there are other factors that people feel are more relevant because these are their children or it's their families and it's more personal, I can't really speak to that. But I will say that I do this for a living. I go to a work environment where I know that there's a high degree of COVID compared to the community. And I have to manage a family, and I have to manage, coming home and all of the rest of what goes with that. And I trust a system that is there to protect me. And I trust that they're not telling me lies or making up things to get me to come to work and do what they need me to do. And if I felt differently, I wouldn't do it. But I think there has to be a level of trust here as well. Without trust, it cannot work. And so I think that that's a very relevant, final point that I'll make is that if you guys can develop an esprit de corps and a trust, it's going to be necessary because this is unprecedented. And we're going to have all kinds of partnerships evolve that might not be intuitive at the outset, but they're going to be necessary. It's going to be necessary because we don't want anyone to